Hi, thank you for listening to my talk on non-viral nitric oxide-based gene therapy to improve perfusion and liposomal doxorubicin sonopermeation in neuroblastoma models. My name is Dr. Shashank Sirsi at the University of Texas at Dallas. The focus of my work is on the development of ultrasound contrast agents, which are small gas-filled spheres that are stabilized by lipid, protein, or polymer shells. They can be designed at any size, but typically they're between 0.5 and 10 microns in diameter. They will contain a lipid, protein, or polymer shell surrounding a small gas core. The microbubbles themselves are much less than the wavelength of sound, but they are still efficient scatterers because of the compressible nature of the gas core. Additionally, ultrasound contrast agents are biocompatible. They've been around for a while. They've been FDA approved for echocardiography and liver imaging, so they are commercially available. Moreover, they are excellent blood pool contrast agents. So when you inject them systemically, they will circulate, and you can image them with an ultrasound scanner. In addition to imaging, microbubbles can be used for therapy applications as well. The mechanism by which a contrast agent works is that the microbubble will respond to an applied sound wave, which is an acoustic pressure wave, by expanding and shrinking in volume. This vibration displaces water around the surface and generates an echo, which can be received by the ultrasound scanner. Additionally, this mechanical vibration can also be used to permeate blood vessels mechanically and allow circulating drugs to extravasate into tissue much better. The strategy that we are employing right now is the use of cationic microbubble contrast agents. So these are positively charged lipid microbubbles that will bind to negatively charged plasmid DNAs. The plasmid DNAs are designed to express an enzyme called inducible nitric oxide synthase, or INOS. With the INOS bound to the microbubble surface, we can inject this systemically into the mouse. Using an ultrasound imaging scanner, we can detect the contrast agent flow and apply focus ultrasound to destroy the contrast agents, permeate the vascular endothelial cells, and deposit the plasmid DNAs where they can translocate to the nucleus. They can generate INOS enzymes in the cell, which will produce nitric oxide. That nitric oxide can then have functional effects, such as relaxation of smooth muscle. It can promote angiogenesis, or new blood vessel growth, or even apoptosis of tumor cells. Our general strategy is to pre-transfect tumors with INOS-expressing plasmids and in order to increase the relative blood volume, improve perfusion, increase vasodilation, and reduce hypoxia in tumors, which is a significant barrier to drug delivery. 3 days following a gene transfection, we will follow this by normal microbubbles co-injected with a liposomal doxorubicin injected systemically, followed by focused ultrasound therapy in order to improve drug uptake and apoptosis in the tumor. First, we determined that we were able to get INOS expression in these tumors with microbubble and ultrasound applications. So here in red, you can see lectin, which is a blood vessel stain. In green, we have an antibody that detects inducible nitric oxide synthase. And in this yellow column, we see the colocalization, or the overlay between the two. So what we're looking at here are a few blood vessels within the tumor that you can see in the untreated and the sham plasmid groups, which sham plasmid is a plasmid that does not express INOS. You were just seeing essentially background staining, whereas nitric oxide, inducible nitric oxide synthase is observed with the functional plasmid treated group. Importantly, we do see that it is mainly co-localized where the blood vessels are occurring, indicating that it is most likely being expressed in the vascular endothelial cells or nearby. We've done control studies in adjacent kidney to the tumor. That's also in the sound field. We've found that INOS is expressed, surprisingly, in the kidney, even in untreated or sham-treated groups, but there's really no difference between the significant difference between the iNOS expression in the kidney. There is a significantly higher level of iNOS in the tumor itself when treated with plasmid DNase. Our next step was to monitor changes in perfusion. So the purpose, we wanted to find out what the bioeffects of iNOS were in the tumor. Our hypothesis was that nitric oxide would relax smooth muscle and increase tumor perfusion. We utilized a custom 3D ultrasound imaging scanner. This is essentially a clinical ultrasound imaging machine with a 2D probe and a stepper motor that allows us to take sequential 2D images, which are reconstructed into a 3D tumor, where we monitor contrast agent perfusion. As you can see with the untransfected and sham groups, perfusion starts to decrease over time, up to 7 days. And with the iNOS treated group, we are able to see a constant level of perfusion. It drops off a little bit here, but if we look at the relative blood volume to the tumor volume, which is what we use to measure the perfusion level, starting at day 0, we're looking at the percent increase. All of the iNOS groups, all the iNOS treated tumors, especially at day 3, where we have the most data points, show a significant increase in the perfusion level. Again, this indicates that iNOS expression is improving perfusion, and then eventually starts to taper off as presumably the iNOS is degraded. Next, we wanted to see if iNOS therapy could improve drug delivery. So here we used liposomal doxorubicin, systemically administered with microbubbles, followed by ultrasound. In untreated mice, we see very little liposomal doxorubicin uptake. With sonopermeation alone, without any plasmid DNA transfection, we are able to get doxorubicin into the tumor. If we followed the sonopermeation and LDOX with a sham plasmid, we see similar levels, indicating the sham plasmid is not having a functional effect. However, with the iNOS, the increase in the nitric oxide, increase in perfusion, appears to lead to higher levels of doxorubicin deposition within the tumor. And importantly, we're also looking at survival, which is less than 50% growth of the tumors. We apply this treatment at day 0 and day 7. At time 0, we were monitoring the tumor size. Once the tumor size reaches 50%, we consider that non-survival. As you can see, untreated controls or LDOX alone, most of the tumors by day 5 have grown beyond the 50% threshold, whereas by sonoperated tumors with LDOX have extended survivals. Importantly, only the iNOS pre-treated tumors with sonoperation and LDOX have 100% survival at 14 days. Unfortunately, our study ends here. We do need to do longer longitudinal studies in order to determine the extent at which these iNOS treatments are able to halt tumor growth for prolonged periods of times, and what are the bioeffects. So with that, the summary of the study is that plasmid DNase and microbubbles together can generate iNOS at significant levels in mouse neuroblastoma tumor models. iNOS-treated tumors transiently increase perfusion, which we measure by ultrasound imaging and contrast agent detection. And there's a significant improvement in systemic drug delivery and survival time in mice treated with the iNOS nitric oxide synthase and sonopermeation. We do want to explore better microbubbles for improving iNOS expression, specifically looking at microbubble size, other ways of packaging the plasmids onto the bubble itself, and also explore longer-term survival and bioeffects of iNOS in neuroblastoma therapy. We also are very interested in exploring the effects of nitric oxide production in tumors and how that can potentially reduce radiotherapy dosages as well as improve chemotherapy dosages. As you may know, nitric oxide is a very potent radiosensitizer. So that's a future direction that we're looking into, and also other cancer types. So we're primarily focused on neuroblastoma models. However, we're looking to neurogliomas, sarcomas as well, and in non-cancer applications. Can we control perfusion in tissue? Thank you very much. Acknowledgements. These are the members of my lab, collaborators at the University of Chicago, especially Dr. Sonia Hernandez, who's doing a lot of the ex vivo analysis, and also clinical collaborators at UT Southwestern and Children's Hospital of Philadelphia. Thank you.